So welcome everyone to our International Colorectal web meeting. As I was just talking to Ray, I think I have not figured out how to see everybody's name yet. So if you wanna be acknowledged or your country, I need you to type in the chat. So far we have representatives from Zambia, Colombia, Egypt, Algeria, Mexico, Thailand, India, Brazil, Trinidad and Tobago, Libya, Romania, Peru, Pakistan, Indonesia, Uzbekistan, Chile, Germany, Italy, and Philippines. So Germany, Italy, and Philippines. So the first presenter will be Dr. Carla Santos from Mexico. So Carla, welcome.
Good morning. Today, I will present the case of a boy that is currently 4 years old, who was referred to us for definitive correction. He has a past medical history of severe constipation and partial distal bowel obstruction. The prior surgical procedures were: 1, colostomy with Hartmann pouch. During the same admission, he continued to be obstructed. He underwent abdominal operation with colonic mapping, appendectomy, and the ileostomy with 2 stomata. The mother said that the patient had enterocutaneous fistula. The colonic biopsy and the appendix were reported normoganglionic, and a rectal myectomy specimen was reported aganglionic. He had a hospital stay for 1 month. This is the clinical appearance of the patient with 3 stomata. On the right hemiabdomen, he had an ileostomy, and the left had a colostomy. How would you complete your diagnostic approach? The option 1 is rectal biopsy. The option 2 is the biopsy of 3 stomata. The option 3 is contrast enema. The option 4 is distal ileostogram, or all the above. The contrast enema show we performed all the above. The contrast enema showed a transition zone at the junction of the rectum with the sigmoid. Here. With the anterior contrast enema, we decided to perform distal ileogram. This is the image show how the descending colon is closed in the Hartmann pouch. We observed the left colon with colitis, stenosis probably function, with adequate pass of contrast through the proximal colon. This is the stenosis. We decided to obtain only a rectal biopsy to confirm the aganglionosis, and we also took a biopsy of the colostomy. The first was aganglionic, and the second was normoganglionic. We performed a proctectomy through a transanal approach. First, we positioned the long start retractor, and then we advanced the hooks for hide the pectinated line in the image of the right. Then we placed a line of seal sutures around the circumference of the rectum for traction. We performed the proctectomy with dissection with electrocautery. The proximal of descendant colon was pulled through and anastomosis to the distal native rectum through laparotomy. The anastomosis was made with interrupted vicryl sutures. The resected segment was 17 centimeters long, including the rectum and the distal colon. In the same procedure, we closed the ileostomy. Currently, 3 months after surgery, the patient has constipations and he takes sema, 17.2 milligrams every day. He has not had colitis, abdominal distension, or diarrhea, and he is fecal continent. Thank you.
Thank you, Carla. Can you go back to the slide where you show the 3 stomas? I just want to make a quick comment. That one. So first, I think if we all have received this patient, it is hard to think what happened and how can we plan the surgery. So whenever we receive the patient that has been operated by someone else, our obligation is to always give the patient the benefit of the doubt and check everything. So I 100% agree. Let's biopsy the rectum, confirm the diagnosis of Hirschsprung. I would inject contrast everywhere, like Carla did. I don't think I would biopsy the stoma itself, but I would be prepared if you have good pathologists available for intraoperative full thickness biopsy at the time of the pull through to confirm that what you're pulling through is the correct segment that has ganglion cells. And you maybe wonder, how can a patient that has a short segment Hirschsprung end up with an ileostomy? And if we all think about, stomas are a very common procedure for pediatric surgeons, but it's a procedure that carries a lot of complication. So doing it correctly is very important. So most likely the patient had a stricture at the stoma site, and that's why he continued to have obstructive symptoms that the other surgeon thought that needed an ileostomy. So it's a fantastic case, and I'm so happy the patient is doing well. Luis, do you want to comment?
No, I just want to congratulate Carla. And yes, if you don't know the patient, you need to take biopsy from the rectum, from everywhere, and do the contrast study from all the sites that we can do it to have a clear anatomic map of the patient. Thank you, Carla, for this case.
So there was a very good question. I understand the patient underwent appendectomy. And the question was the appendectomy a good choice? So I would say no, it was not a good choice. In patients with Hirschsprung, myelomeningocele, anorectal malformation, we should do our best to preserve the appendix. We have recently published a paper that we recommend if you want to rule out total colonic ganglionosis. My suggestion, you have to map the entire colon. So you need a rectal biopsy, a sigmoid biopsy, and a descending colon, a transverse colon, and ascending colon. And you can take the tip of the appendix and send it as a specimen. But you should not take the entire appendix because, of course, this patient received a good operation. So the patient has bowel control, is not fecal incontinent. But in the event that the patient suffers a technically deficient operation and needs a Malone, it is good to have the appendix available. Okay, so any other questions? If not, Carla, if you can stop sharing screen, then I'll try to share mine, and bear with me because I hope I can share it correctly. Can you see the slides saying case number 2?
Perfectly, yes.
Yes.
Wonderful. So this is a 3-year-old male patient, ex-preemie. He was born at 35 weeks. That was born with the diagnosis of covert cloacal exstrophy, tetrachord with an intradural lipoma, patent foramen ovale, atrial septal defect, malrotation, and bilateral hydronephrosis. So here's the first image, and you can see a very distended bowel in this portion, and you can see that the patient has an OG tube. Patient had bilateral hydronephrosis, so here you can see the right kidney and the left kidney. Tetrachord, remember the definition of tetrachord is that the conus ends below the inferior rami of L2. So in this case, you can see it goes all the way down. This is the image of the bladder, and you can see tiny bladders that are like bilobulated. So again, this is the bladder, and it's a bilobulated bladder. And then when you continue to inject contrast, you can see that the bladder descends a little more. This one is bigger than this one, and you see this abnormal piece of colon attached to the bladder. Again, this is the colon, the piece of colon attached to the bladder. And when we rotate the patient, you can see that the piece of colon enters in between the bladders. So at 2 days of life, the patient underwent ileostomy and mucus fistula creation. So my first question is, what is your opinion about that? So with a short colon, tetrachord, hemivertebra, this was the right decision. Or the patient should have undergone an end colostomy, or I don't know. So everybody please vote. Do you all see the poll? If you see the poll, please vote so we can close. Do I close the poll, Ray?
No, I will do that. I just want to show the results here.
I'm just gonna wait to see if there is, do I see the results? I don't see them.
They just went away.
Okay. So, and you didn't see it either?
Yes, I saw it. Everyone saw it.
So what was the result? Because we don't see it.
Oh, the second.
So the majority voted that patients should have undergone an end colostomy.
Correct.
Oh, congratulations. Did anybody answer number 1?
Yes, about 13%.
Okay, perfect. Not perfect. We will discuss why it's not perfect. Now, the patient comes to you at 3 years of age. So what is your recommendation? Ileostomy closure and pull through, rescue operation, ileostomy closure, colovesical fistula ligation and creation of end colostomy, or I don't know. So Ray, just so you know, I don't see any votes and I don't see any results. So you have to tell me.
Okay, this is going on. You won't see it until the end of the poll. Right now we have 13% with number 1, 82%, 83% with number 2, and 6% at I don't know. But they're still voting.
Okay, I'll show you so you'll see how I see later. Yeah, it doesn't move for us. So
I end the poll now, and we should all see the results, correct?
now I see it. Perfect. So 80% said rescue operation. That's the correct answer. So I'm glad some people didn't choose the correct answer, because then it means we can discuss and learn. So here is just a simple abdominal x-ray so you can appreciate the sacral defect, the separation of the pubic bones and the hemivertebras. So this is a study that we did prior to our operation, that was the rescue operation. So we inject contrast and now the colon seems to be all in this side. So it's almost as if the surgeon had a colon like that and they made it like that now. So all the colon is in one side. And this is what we found intraoperatively. So the head of the patient is in this side. Here's the penis, and you can see the bilobulated bladder here. And this was the bowel connected to the bladder neck, and there was an intra-abdominal left testicle. So here is my diagram, and I'm not so good in making drawings, but hopefully you can understand. The bladder neck was open. It was a bilobulated bladder. This was the colovesical fistula. Patient had a very abnormal diverticulum that almost looked like mucosa only. And then the colon was also bilobulated, very floppy, like a pouch colon. So it was here, then there was a very narrow portion that measured approximately 1.5 centimeters, and then the other piece of the colon. But this piece was like that. So that's where the stoma was. The patient had an ileostomy and the mucus fistula. So this was the previous mucus fistula. So we separated everything. Those operations are not easy. It took us about 3 hours doing lysis of adhesion. And then we had all the ileum and the small bowel. And this was the piece of colon. It measured approximately 10 centimeters. And that was this abnormal diverticulum. It had a very abnormal tissue, very thin. So we just resected that. So here is the final anatomy. So we ligated the colovesical fistula. We left the bladder intact. We removed the diverticulum and we made a wide connection between the ileum and the colon and a true end colostomy. So all the colon is now incorporated into the fecal stream. This is very important because even when this piece of colon is short, if it's not incorporated into the fecal stream, it does not grow. So I'm not going to give the answer because I think there is a question. So that was we used the same incision that we removed the stoma. So he had the orchidopexy and we made a true end colostomy. Now, what would be the next step? Bowel management through the stoma to determine if the patient is a candidate for stoma pull-through or stoma pull-through with a Malone and bowel management to treat fecal incontinence, or I don't know. So everybody can vote.
And we'll see the results at the end of the poll. We've got 81 on number 1 right now, 81%, and 18% on number 2.
Perfect.
I'm still voting here.
Let's see the results. Okay, so the majority said bowel management through the stoma to determine if the patient is a candidate for the pull-through. That's the correct answer. And now we're gonna go back to a few slides to explain everything. So as I was explaining, when you have a patient with a short piece of colon, those are patients with cloacal exstrophy or covert cloacal exstrophy, you have to incorporate all the colon into the fecal stream so that piece of colon can grow over time. And we don't know at birth if that piece of colon will work or not. And by work, I mean if it's gonna respond to bowel management or not. So the only way to know if it's going to respond to bowel management is testing it. So what we do is we do bowel management through the stoma. We inject the enema. The patient has a massive bowel movement immediately after. And then we want the stoma bag to be empty for 24 hours. Those patients need a concentrated enema, small enema in volume, because it's not a huge colon, to clean that pouch. And usually they need Imodium to slow down in between enemas. So if we have an empty bag for 24 hours, then we know, and the patient know, the effort that they will need to do every single day if we bring the stoma down as the neoanus. So then the family can decide if they want to have a pull through. It's very important to test before. If I pull through immediately and it doesn't work, then I have to revert the surgery. Now, if I do the bowel management and it doesn't work, then this piece of colon can be donated for the bladder, for bladder augmentation. Now, if it works and I'm gonna do the future pull through, then I stay, colorectal stays with the entire colon, and then urology will have to use either small bowel or stomach for the bladder augmentation. So making an ileostomy in these patients is the most common mistakes. So this should not happen. So for those that voted wrong, I hope I have clarified. If not, please type in the question and answer, and I'll be happy to address all the questions. So there was a question, did you reconstruct the hemibladders? Not yet. We will reconstruct the bladder at the time of the pull-through if the patient is a candidate for the pull-through. So probably in 1 or 2 years from now. And then there was a question, does the patient need pelvic osteotomy during the pull-through? No, this patient does not need. Patients with cloacal exstrophy, sometimes they need pelvic osteotomy mainly to help for the closure of the abdomen and the bladder. This patient has an intact abdominal wall. This is a more benign form of cloacal exstrophy. For how long do you try the bowel management before decision to take it down? And what age do you start to test? Very good question. So normally, in the ideal scenario, this patient would have had the correct operation at birth. So I would start testing around 3 years of age. And then we would give the patient about 1 or 2 years. So 1 to 3 trials. And if they fail, then we would advise for a permanent stoma. Is there a perfect age for the descent? We usually say in the United States, they want kids to be clean for stool and dry for urine in normal underwear around age 5 when they enter kindergarten. So that's the age we currently use in the United States. But this is a quality of life decision because when the bladder is draining freely, the kidneys are protected. Now, once we do a bladder augmentation, the patient will need intermittent catheterization. When we do a pull-through, the patient will need enemas. So the family really has to understand all that it will take in order to keep that child clean for stool and dry for urine. Any other questions? Luis, Carla, any comments?
No, I don't think so. This is a case that shows very clear how to do a rescue operation in a patient with this type of malformation. So I think you explained everything very, very well. Thank you.
Okay, so now we're gonna move to the next case. Oops, it's showing again case 2, 1 second. Let me see if I
There is a question in the Q&A window. They are asking you, what is the incidence of Hirschsprung in this colon?
I've never seen a case of Hirschsprung in a pouch colon. And the incidence of Hirschsprung in cases of anorectal malformation is extremely low. Unfortunately, because these pouch colons, they don't have a good motility, people confuse with Hirschsprung. And it's very important to understand the difference, because if you remove this colon, then the patient has absolutely no chance of ever having a pull-through. This is very important because patients, for example, with ulcerative colitis, they are born with a normal anus. So even when you remove the entire colon, they can have an ileoanal pull-through. Patients with total colonic ganglionosis, they are born with a normal anus. So if you do the operation correct, you remove the entire colon, you do an ileoanal anastomosis, and the patient has bowel control. Now, patients that are born without the anus, if you bring the ileum, you're gonna do a perineal ileostomy, and the patient has the worst diaper rash, unmanageable, and there's no bowel management into the ileum. Remember, the small bowel is the one that absorbs nutrients, so we cannot do bowel management in the small bowel. And bowel management only works if the patient can form solid stool. And in the small bowel, there's no solid stool.
And the other question is, if in these patients, are you going to do a bladder augmentation?
Yes, this patient will need a bladder neck closure, bladder augmentation, Monty-Mitrofanoff, and if the patient succeeds in bowel management, we'll bring the colostomy down and make a neo-Malone. This patient did not have an appendix, and I suspect that it was taken out during the operation, during the first operation, which was also a mistake.
And finally, when do you recommend to do the pull-through?
Yes, that I already discussed. Usually in the United States, we do around 5 years of age. I don't recommend testing bowel management before 3 years of age. The reason is, if you think about the type of food in babies, babies are constantly either breastfeeding or drinking formula milk. So, and they are drinking at different times. So it's much harder to do bowel management for those patients because they have a fast motility, that it's the small bowel, and a pouch colon that have a slow motility. We have to clean that colon, and then we have to slow down the motility. So it's important that they have 3 meals per day, constipating diet. They will be taking Modian. So we want meals at the same time. And before 3 years of age, this is very hard to achieve.
And I think there's another one. It says, did you reconstruct the hemibladders?
No, I already mentioned that we did not. We will just reconstruct at the time of the pull-through, if the pull-through is indicated, usually around 5 years of age. Any other questions?
Okay. Yeah, what about the tether cord?
The tether cord, he was operated for that. So that has already been released. Any other questions?
Yeah.
Let's see.
I think that's all for now. No, I'm checking.
Good.
So you can go on with the case 3.
Okay, perfect. Okay, so case 3, it's a very interesting one that I just received an email about. And for anyone in this meeting, if you ever want to discuss a case in an anonymous fashion, meaning that you don't want to say that it's your case because there was a complication, feel free to tell us. The whole purpose of this meeting is learning and sharing knowledge. So if you would rather not tell that it's your case, just send the case and I'll be happy to present for you and discuss so everybody else can learn. So let's suppose that you have received the following email from a colleague. It's a male patient born with an anorectal malformation. You decide the patient underwent a primary PSARP plus laparotomy for, and I put under quotes because I haven't seen any study. So for a rectal bladder neck fistula. Apparently the patient did well. He was discharged home and started anal dilation 2 weeks after surgery. Then he recently started passing stool per his urethra, and then the surgeon did a contrast enema. So here is the contrast enema done now. Just remember this patient underwent a primary pull-through. The patient does not have a colostomy. And here you can see through the arrow the connection between the rectum and the urethra. For me, this connection looks to be at the prostatic level. So what would be your recommendation? Open a vesicostomy and continue with anal dilation. Open a vesicostomy and stop anal dilation. Open a colostomy and continue with anal dilation. Open a colostomy and stop anal dilation. Or I don't know. Everybody can vote.
It's about even between number 3 and number 4 right now. They're still voting.
So most people are saying open a colostomy, and there's debate between the anal dilation. Okay, we can end the poll. Oh, it's a very divided audience. Okay, very interesting. So let's look again at the contrast enema. So with this contrast enema, knowing that the patient has a fistula, I have to say that I am very concerned that this distal segment will not be useful. And the other thing is, for sure, you will have to take the anoplasty. Therefore, my recommendation would be stop anal dilations. This is a real stricture. When you have a real stricture, anal dilations are very painful. Anal dilations are not to dilate real strictures. They are just to avoid natural healing process. So if we continue dilation, this is going to be very traumatizing for the baby, for the parents, and then you will have trouble next time when you need the anal dilations to avoid the natural healing process. So my recommendation in this case was to open a colostomy and stop anal dilation. So the next question is, how long would you wait before attempting a reoperation? 1 month, 2 months, 3 months, 4 months, 5 months, 6 months, or I don't know. Everybody vote. Okay, let's close the poll. 6 months. Very good. I would say any answer after 3 months is okay. Attempting a reoperation before 3 months is going to be very hard. I would say open the colostomy now. The longer you can wait, the better for the child and for you, because then the reoperation will be a little easier, but reoperations with complications are never easy. So what studies would you do before the reoperation? MRI, CT scan, high pressure distal colostogram and voiding cystogram, no studies are needed, or I don't know. Everybody can vote. Very good. So 85% said high pressure distal colostogram and voiding cystogram. I think that's very important. So you know how much distal bowel you have, and also the voiding cystogram, so you can determine exactly where in the urethra is this connection. And because the patient supposedly had a rectal bladder neck fistula, you also want to inspect everything. So at least a high pressure distal colostogram and the voiding cystogram before you operate on this patient. You will need a Foley catheter and be ready for a difficult operation. So any questions about this case? I think one question that we could discuss is, where would you do the colostomy? So type in the chat, where would you do the colostomy? Thinking that you will need to reoperate on this patient, and ideally you want to be able to mobilize as much colon as needed for a perfect pull through. Remember, this is already your second operation. You cannot have another mistake. So let me see what people are typing as options. Anybody's typing? Let me see. Proximal descending colon, proximal sigmoid, proximal transverse colon, ileostomy, 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 transverse colon, proximal. Very good. We have a divided audience. So in this case, I suspect that the distal portion you won't be able to rescue, just based on what I'm seeing in the image of the contrast study that shows a very stricture, narrow, abnormal distal colon. So I suspect all of that you won't be able to use. So you will have to mobilize this splenic flexure. So to be safe, in this case, I would do a transverse colostomy. I would prefer not to do an ileostomy if you can avoid, just because a colostomy, it's easier to manage, but there's no mistake in making an ileostomy. You just want to be able to have the entire colon, so, or have enough colon to be mobilized and have a good pull through this time. Any other questions about this case? I just thought it was a very interesting discussion, and I just want to emphasize that if you have a real stricture, you should not attempt to dilate. Anal dilations, the purpose of anal dilations are not to dilate real stricture. And in this case, when the patient will need a reoperation, don't traumatize the patient. Otherwise, when you actually need the anal dilations, you will not have cooperative parents and patient. Any other?
There is one question. Yeah,
Yes.
there's one question. It says, do you think that this fistula was the original one, or it's iatrogenic?
That's a very good question. I don't know. The surgeon that wrote to me said this is iatrogenic, because they said, they claimed that they clearly saw the rectal bladder neck fistula. So I don't know, because I was not in the operation, and I have not seen the original studies when the baby was born. Remember, this case, there was no distal colostogram because it was a primary repair. So I don't know. So there is a question, why not a redo PSARP without a colostomy? Well, that's a very good question. I think we already had a serious complication, and you cannot afford to have another complication. So doing a redo PSARP now, you cannot wait, right? The patient needs something done now, because this distal rectum will close. So the question is, doing a redo PSARP in a freshly operated case with a current fistula, I think the chances of damaging more are very high. So I think you already had one complication, you have to take the safest route. And that means a colostomy, let everything heal, do a distal colostogram, have all the studies. Otherwise, you know the Swiss cheese model, that in order to have it, when a catastrophe happens, there were serious layers that were invaded. And I think when you have a mistake, you have to step back and do what's the safest thing. So in my opinion, for this case, I would not redo a PSARP without a colostomy. I would recommend a colostomy, a well-done colostomy, leaving enough distal bowel for good mobilization, let it heal completely, make sure it's perfect before you close this colostomy. If you have a second complication, then the parents will not forgive you.
There is another question. What was wrong during the first operation, and then how to avoid this complication?
Yes, I was not there, but I can tell what are the common mistakes. The common mistakes is when you pull under tension and with poor blood supply. That's how stricture happens. And now how the fistula happened, usually fistula happens because you damaged the rectal wall and you damaged the urethra during the repair. That's usually how fistulas happened. Let me see. Are there any other questions?
Look, the first procedure was.
Looks the first procedure was done without colostomy and poor blood.
Colostomy.
Yes. Any other questions? If not, we're gonna move to the last one. The last case is a very simple case, but the reason why I'm presenting is because when I think about all the cases that we present during this meeting, we usually present surgical cases because we're surgeons, we love to operate. But a huge part of our practice for those that do a lot of colorectal surgery is bowel management. So I'm gonna try to start bringing more and more bowel management cases because I want at least everyone that attend these meetings to be really familiar with bowel management. In this case, I didn't prepare fully showing the cases of how we should present, but wait, I'm not seeing my case here. Give me 1 second. Let me close the other ones. But I really want everybody to learn how to do bowel management. Ray, I'm gonna try to share. If not, I'll have you share because somehow it disappeared here.
Okay.
Yeah, it's not showing me.
Hold on.
It's case number 4.
Yep.
Is the final operation a PSARP? Also after colostomy. So for this operation, most likely the patient will need PSARP and laparotomy. And my recommendation would be do the colostomy now, wait, ideally 6 months, but at least 3 months. And then you're gonna do the redo PSARP with laparotomy. The segment that was stricture looked to me like this big. It's a big segment. So you will have to bring good bowel from high up down to the perineum. You really need to see all the vessels, all the blood supply. So, so you have a good pull through this time.
Yeah, there is another question.
Yes.
I think it's from the previous case. I'm not sure.
Mm.
It's from an anonymous attendee. It says, do you have to do voiding, cystourethrogram, or just the colostogram?
So in this case, I would like to see exactly where the fistula is, and I want to make sure that the bladder is fine. So I would do a voiding cystogram and a distal colostogram. The essential study is the distal colostogram, but I would recommend doing a voiding cystogram too, because I want to see the entire urethra. I want to see the entire bladder. Okay, so we're gonna move to the next case. I think you will have to move the slides for me.
You should be able to do it yourself. Can you give it just a quick try there? There we go.
Oh, perfect. Okay. So this is a 7-year-old male patient with history of fecal incontinence. And that means that the mom comes to clinic and tells you that the patient cannot control the stool. They have stool accidents. So how can you determine if this is a case of constipation with overflow pseudo-incontinence, or if this is a case of true fecal incontinence that the patient does not have bowel control? Option 1, history, physical exam, and contrast enema. Option 2, trial and error. Option 3, I don't know. Everybody can vote. So the history, physical exam, and contrast enema should give you a hint, especially when we get, for example, in patients with anorectal malformation, if we get the sacrum, if we look at the sacrum, we know, if we know the type of malformation, we should know how is the prognosis. For patients with Hirschsprung, knowing the integrity of the anal canal is essential to determine if they will have bowel control or not. So in this case, the patient had no previous medical history, meaning he was never operated, does not have tetrachord, had no other conditions. And on the physical exam, he had a normal anus. He was not developmental delay, he was normal. So we have everything to believe that it's a case of constipation with overflow pseudo-incontinence. So here is the contrast enema, and I want you to look carefully at the images. So this is the pre-evacuation image when you're seeing the entire colon, and the post-evacuation image when you see that you still have residual contrast. So with this contrast enema, what do you recommend? Motility studies such as colonic and rectal manometry, SITS marker study, this patient needs a full thickness rectal biopsy, bowel management, or I don't know. Everybody can vote. Okay, we can end the poll. 28% saying this patient needs motility studies, 10% saying this patient needs full thickness rectal biopsy, and 63% saying the patient needs bowel management. Wonderful. So I'm gonna go back, and Dr. Luis de la Torre will also comment. This is a classic image of idiopathic constipation. You see this dilated rectosigmoid. This is not Hirschsprung. This patient does not need a full thickness rectal biopsy. Constipation is an extremely common condition, but it's very different from Hirschsprung. Luis, do you want to comment?
Yes, thank you. I just want to say that you need to keep in mind that the patients with Hirschsprung, they have micro rectum, no mega rectum. In other words, you are doing a contrast enema and you see a dilated, enlarged rectum, is not a Hirschsprung patient. The patient with Hirschsprung has a rectum which is small compared with the normal rectum. So you need to keep in mind the patient with Hirschsprung has megacolon or congenital megacolon, but it's not megarectum, it's microrectum. So keep in mind this difference, and it's going to help you to understand the contrast enemas. Yeah, thank you.
So this patient went to another center where he received all the motility tests. And from our experience, the motility tests do not help. At the end, if the patient has constipation, the patient needs bowel management. If the patient has fecal incontinence, the patient needs bowel management. So what truly helps the patient is the bowel management. So in this case, he was started on enemas and was successfully cleaned in the underwear for stool with 400 mL of normal saline and 30 mL of glycerin. So now the patient comes to you, the patient came to me. So what would be your recommendation? Offer an antegrade enema procedure, a cecostomy or a Malone, or offer a laxative trial, or I don't know. Laxative trial means we're going to try to stop enemas, give them laxatives, and see if he can achieve voluntary bowel movement and stay clean in the underwear only with oral laxatives. So 95% said offer a laxative trial. Very good. So that's what we did. So, oops. The patient underwent a laxative trial. So on the first Friday, I started him on 3.5 squares of X-Lax. The first 3 days, he did well. On the fourth, and remember, our bowel management is a week-long treatment. So it's from Friday to Friday. We get daily X-rays and report. And based on the X-ray and the report, we adjust the dose, the treatment as needed. So for him, I started with 3.5 squares. Again, the first 3 days, he did good. The fourth day, by the time I had my consultation, he did not have a bowel movement, but his X-ray was still clean. So I did not increase, which was a mistake. The next day, his X-ray was full. Then we had to give an enema and increase to 4.5. And now it has been 2 months. He's on 4.5 squares, that's 6.7 milligrams of senna and 1 tablespoon of fiber 3 times a day. And he's completely clean in the underwear. For the next cases that I'm gonna bring, I'm gonna show you the X-ray so you can start being familiar with how the X-ray looks like. But again, it takes us 1 week to find out the correct treatment, and we don't let the patient go. We keep following them. So any questions about this case? This is the X-ray that was done last week, and you can see that the patient is doing well. Any questions about this case? Any comments, Luis?
Well, yeah, no, there is a question for you. It says, what about short segment Hirschsprung?
Okay, I'm sure you want to comment that. So we don't.
Go ahead.
We don't believe in ultra short Hirschsprung segment. Remember, when we do our operation for Hirschsprung, we start the dissection between, usually I try to do it 2 centimeters above the dentate line. So I leave this ultra short Hirschsprung segment, and the patients have no problem throughout life. So we don't believe in ultra short Hirschsprung segment. Luis, do you want to comment?
Yes, there is another question and I want to answer. What about the ultra short that you already respond and the intestinal neuronal dysplasia? Do you think a rectal biopsy should be done to rule out these conditions or them? Yeah, so every time we have a patient, the definition of Hirschsprung is absent, lack of ganglion cells in the bowel. If we have ganglion cells, we cannot say this is a Hirschsprung patient. Ultra short should be related with achalasia. Achalasia is a diagnosis that we cannot make with biopsies. We cannot confirm with contrast enemas. Usually, the diagnosis of achalasia in the anal canal is done by a rectal manometry. And the definition is a patient with no anorectal reflex and ganglion cells or positive ganglion cells in the rectum. So this is more a manometric diagnosis. So this is usually done by the GI group or the motility group. As a surgeon, we don't do this diagnosis doing contrast enemas or biopsies. That's my opinion about this.
I want to respond one question. To avoid X-ray, we would use sonography. The radiation dose of an abdominal X-ray is similar to days of regular radiation, 2 days more lives. We don't have to afraid to that amount of radiation. I am doing a radiation job. That's why I am getting data.
So there are more questions here. Let me see if I can answer all.
Yeah, there is another one about, it says, good morning. If at the beginning of the laxative trial, this doesn't work, how many times do you recommend to try, I assume, the laxative trial before a Malone surgery? So this is a very tricky question.
Yes. So in this case, usually our bowel management week is 1 week. But during this week, you can sense if we're moving in the right direction or in the wrong direction. Meaning if the patient have unpredictable accidents all the time and you still have, even with a good x-ray, then probably this patient will not respond. I would say I would go back to enemas because enemas work and try again on the next school break. I emphasize to my patients and to the parents of my patient that our job is to avoid accidents at school. We don't want kids to suffer, to be traumatized. So during the school year, I want them to be confident that they can be clean. And then every vacation, we will try again. So it is very unusual to fail a laxative trial in a normal child. It happens, but it's very unusual. Usually with the right amount of laxative, right amount of fiber, sometimes limiting snacks is very important. So they're not constantly eating, but usually we succeed. And if they don't succeed, then it's a discussion with the parents if they want to continue doing rectal enemas or if they want to proceed with Malone. There was a good question. Why didn't you start directive with a laxative trial? That's a very good question, because the patient didn't come to me originally. But I have to say, it depends when the patient comes and how much they have been suffering with stool accidents. With enemas, it's extremely easy to make them clean like that. Of course, it's invasive, but you keep them clean. So if the patient has been suffering for a long time, or if the patient is also having stool accidents and the patient is older, sometimes I would recommend starting with enemas. And if we are clean in 3 months, then stop and do a laxative trial. Now, if the patient was local and the family was willing to try, and that means not sending the child to school until we are 100% sure that this regimen is working, I would start laxatives right away, because this patient had all the indicators that he would succeed, that it was just a case of constipation. Is there a role of Botox in these patients? I don't recommend Botox for constipation. The Botox has a temporary effect, and we're dealing with a chronic condition that will not go away. So we have to find a regimen that manages the constipation on daily basis. So I don't recommend Botox for this case. Do we need to give more than type of laxative? Senna. We use Senna. That's the one that provokes the bowel movement, and that's the one that has best results in our patients. Any other questions? I think we're running out of time. So I just would like to thank everyone. And remember, we have on March, our next colorectal web meeting will be March 24th, but we also have our Peña course that is going to be free and virtual March 31st and April 1st. So if you have not registered yet, please do it. You can register through the Handwritten Project if you're not looking to obtain CMEs. But if you need CME, you have to register through the Children's Hospital Colorado website. So thank you again, participants from Zambia, Colombia, Egypt, Algeria, Mexico, Thailand, India, Brazil, Trinidad, Tobago, Libya, Romania, Peru, Pakistan, Indonesia, Uzbekistan, Chile, Germany, Italy, Philippines, and Lebanon, and United States. I think I did Spain. I hope I didn't miss anyone, because otherwise I publish and then people complain. Bahrain, thank you. So we hope
Andrea,
to see you in March. Yes, Luis.
can you clarify, there is in the chat, if they had the registration on the Children's Colorado or through the Henry Project, any registration is they are going to have a diploma or whatever?
That's a question for Ray. I know if you register through Children's Colorado, you have diploma. Ray, is the Handwritten Project providing diplomas too?
We would be able to do the same thing through the Handwritten Project, yes. So everyone registering through us would be able to also get a certificate.
Perfect. So you will have certificate. I can say registering through the Handwritten Project is much easier, but do whatever is needed for you. Thank you.
It's easier from the Henry Project. That's why they are asking about the diploma.
Yes, perfect. Okay. Bye-bye, everyone. We'll see you in March.